Can you see my screen? Okay. Can you see the first slide? You can see the slide? Yeah. Tell me when to start. And maybe you can record the lecture.
ترحب المطر.
Recording in progress.
Okay. Okay, good. Hello, everyone. Good morning. I am Manu Malbrin. I am an internist intensivist from Belgium. And I've been ICU and Chief Medical Officer, Director in different hospitals in Belgium. I am currently affiliated to the Medical University of Lublin, and these are my disclosures as I consult for different companies. What I will also do today is to share with you some results of a recent study on the fluid use in Belgium. And this is the outline of my talk, so let's kick off with a short introduction. Imagine orchestrating a symphony where each note contributes to the harmony of the whole. Likewise, in critical care, we have to find the delicate balance between fluid overload, which can be detrimental, as well as hypovolemia. Now, already 10 years ago, we wrote this editorial on fluid management, and I will take you back to ancient Greek mythology, where Homer had his Odyssey. Now, when he was traveling over the seas for many years, at some point he encountered Scylla, which is represent this as hypervolemia. Now we also have to pass Charybdis, which is like a vortex, and I think this resembles hypovolemia. Now, when he was traveling between Scylla and Charybdis, he had to make a choice. Now, Homer chose to pass by Scylla. Because of this, he lost 6 of his men, that the ship could move on. Now, this just to illustrate the delicate balance between hypervolemia and hypovolemia, or Scylla and Charybdis, as both may lead to organ dysfunction. Now, if I would ask you, why are you giving fluids? Some may say, I give fluids to improve stroke volume or blood pressure, or maybe to improve tissue perfusion? I guess all answers are correct, but we need in order to take the oxygen-rich fluids to the microcirculation. And this is a healthy capillary. And this is the same capillary only minutes after an insult. So capillary leak is like a leaky bucket, very, very fast. Now, here you look at immunofluorescence of a hamster cheek pouch, and this is after 10 and 30 minutes, but now capillary leak can occur at a distance. Because of that, patients are at risk for fluid accumulation syndrome. If I would ask you, what is this? You would say it's seagrass at low tide, and here we see it at high tide. Why am I showing this video? Because it nicely represents the glycocalyx, which is a glycoprotein shell, a layer between the vascular lumen and the endothelium. And it protects free movement of water, electrolytes, and proteins. So the balance between the macro and the microcirculation is important, and we know that sepsis is a time-critical emergency. Now in medicine we have many time-critical emergencies like myocardial infarction, ischemic stroke, polytrauma, we need to have imaging, and in sepsis we have this 1 hour or 2 antibiotic or IV fluid. So maybe we have a golden hour to preserve organ function. Now the reason why we are giving fluids stems back from the old age of the blue stage of spasmodic cholera, where we saw that these patients are profoundly hypovolemic and fluids can be life-saving. However, if you give fluids, the effects are short-lasting. Now, only give fluids when patient is in shock, there is hypovolemia, tissue hypoperfusion, patient is fluid responsive, fluid tolerant, and there is no risk of fluid accumulation syndrome. Now, why do fluids matter? Fluids can be life-saving, but they can also cause harm. You're probably all aware of antibiotic stewardship, and we should treat the fluids in the same way, because they can lead to electrolyte disturbances, acid-base disturbance, and morbidity as well as mortality. Probably it's the same in Yemen that about 80–90% of patients in the hospital may receive IV fluids. 1 patient in 5 will suffer from complications, too little or too much fluid. So we should look at fluids as we do with antibiotics, the drug, the dose, duration, and the escalation. Now, from all the fluids that we give, it's not just for resuscitation, but about 1/3 is fluid-free. These are little bags of saline, glucose, that we dilute other drugs in, like antibiotics, painkillers, antacids. Now, what about the knowledge of fluid composition, fluid indication? In the survey of global survey of over 1,000 respondents, the average score was 46. So we did not pass the test. And it's probably the same if we would do the test in Yemen. So the average knowledge scores are about 50%. Now the final reason that I got a personal interest is that when I was a medical student, I exactly received 0.0 hours of education and training. So these are the problems with IV fluids. So that's why there is a need for fluid stewardship, to reduce complications, to improve outcomes. So let's illustrate with a case. Fluid accumulation syndrome is a syndrome It's not a disease. It can occur within many conditions and diseases. Now, this is a picture of an ugly fluid that I asked my wife to take before I was undergoing major surgery. Now, following the surgery, I developed fluid accumulation. I gained 8 kilos, and you can see my abdomen is distended, and my right hemi diaphragm was almost at my neck, and I had difficulties in breathing. So I can tell you that fluid accumulation and abdominal hypertension are real, but many of our colleagues don't pay proper attention. Now let me illustrate with a typical case of a perforated viscus to the ICU with abdominal sepsis. Now blood pressure may be low, or urine output may be low, or CVP may be low, or maybe the passive lactase is positive. So let's give some saline. Why is that? Because it's kind of a reflex. Whenever something goes wrong, we have the perception when we are administering fluids, we are actually treating our patient. But you can see on day 2, the abdomen is distended, creatinine is increasing. Next day, there is oliguria, positive cumulative fluid balance, CVPH has been started, and on the next day there is a sudden cardiac arrest, there is a decompressive laparotomy, so the patient developed secondary abdominal compartment syndrome leading to acute mesenteric ischemia following fluid accumulation syndrome. So intra-abdominal hypertension is a killer. But the question here is, did we do everything to prevent fluid accumulation syndrome, and are we changing our mindset and thinking fluid stewardship? Fluids are drugs. Well, we are humans. Humans make mistakes, but let's forget the mistake and remember the lesson, and above all, let's break some bad habits. That is why the International Fluid Academy was founded almost 15 years ago, and we publish open access papers and guidance on fluid stewardship in sepsis and the perioperative phase on COVID patients. We also support research, and we also looked into fluids and abdominal hypertension as my personal case. Now, one of the recent papers is a review that helps you how to implement fluid stewardship in your hospital. For those who have not yet downloaded, there is a free open access book that has now been downloaded over 1,750,000 times, so I invite you to do so. This tells me 2 things. One, people like it when we are giving away free books, of course, because it's free, but it also tells me that there is a knowledge gap and that colleagues want to learn more about fluids and fluid stewardship. Now, let's go back to the case and the legal implications. In Belgium, I just finished a master in insurance medicine, and patients like the second one I presented may found the healthcare providers liable of misconduct, of mistreatment. So I think fluid accumulation syndrome may pose us healthcare providers at risk for liability, and this is an important factor if we want to improve care. Now, going back to the literature, I would like to present you the 10D framework with definitions, the diagnosis of hypovolemia, hypervolemia, fluid responsiveness, distribution of fluids, and then we have drug, dose, duration, de-escalation. These are the four Ds that we know from antibiotic stewardship. Moving on to documentation, and yes, I have to admit, I asked AI, ChatGPT, give me 10 nice words with a D, and this is what came up. I like diligence because it represents the carefulness in the way we treat fluids as drugs. So when you have D1 to D10, D to the power of 10, and this is what I should call fluid stewardship. This is what you should be doing in the ICU at the hospital. Now briefly, definitions. This is the first chapter of the book. It's about 40 pages where all current terms and definitions are listed. Because we know that fluid overload may lead to hypervolemia, hyperhydration, and peripheral edema because of hydrostatic forces. The opposite is not always true. It's not because you're edematous that you're also intravascularly hypervolemic. And that's why Jean-Louis Vincent, also from Belgium, states we should avoid the term fluid overload because it's misleading for some of our colleagues with hypervolemia. Now, everything you need to know can be found in this open access paper on deresuscitation and a more recent review on fluid accumulation syndrome. Now, instead of talking about fluid overload, we propose fluid accumulation, so you look at the fluid balance or change in body weight. Maybe in the future we can quantify peripheral edema or measure the circulating blood volume or look at volume excess with biological beams analysis. Now, fluid distribution, we know that 2/3 of the fluid is in the cell and 1/3 is extracellular, out of which 1/4 is the intravascular fluid. Now, when we talk about fluid accumulation, we talk about an increase in the extracellular water, whereas hypervolemia is increase in the intravascular fluid. A fluid accumulation syndrome is any percentage of fluid accumulation with new onset organ failure related to the accumulated fluid. So this could be pulmonary edema, high lung water, abdominal hypertension, taxus, kidney congestion, and so forth. Now the second lead is on diagnosis, which is important because hypovolemia is bad, we have convective problems, but hypervolemia is also bad. We have diffusion problems. That's why the prediction of fluid responsiveness, but maybe also unresponsiveness, and this is summarized in this review paper where we list different techniques to assess fluid responsiveness, from the passive lag race to pulse pressure variation, and expiratory occlusion, time to volume challenge, and so forth. Because fluid responsiveness can be combined with hypo or hypervolemia and fluid accumulation with profound or little peripheral edema. In between is a new term, which is fluid tolerance, which is the maximum amount of fluids that a patient can tolerate before developing fluid accumulation syndrome or deleterious effects. So when a patient becomes fluid unresponsive, venous congestion, we state this fluid intolerant. And the interplay between fluid responsiveness and tolerance, and there are different combinations possible, will determine the risk of fluid accumulation syndrome. But to complicate things, the fact that you're fluid responsive does not mean that you're also fluid tolerant. So these are separate entities, and this was shown in this study that patients who are fluid responsive may also have some venous congestion. And that's why the fluid status matters, but there are a lot of myths and misunderstandings. Not all septic patients are hypovolemic. At the very beginning, they may just be vasoplegic. And that's why, illustrated in this video, vasoconstriction, like norepinephrine, may be beneficial. And you can see that when we squeeze the bottle, vasopresses, you increase the stress volume and you improve venous return. We already discussed, peripheral edema doesn't mean that the patient is hypervolemic and diuretics are needed. It's not because preload is low that fluids are needed. And it's not because you are fluid responsive that we need to give fluids, or that the patient is hypovolemic or the patient is fluid tolerant. Because fluid responsiveness is the normal situation. You all here present today, you are fluid responsive as I speak. Now, The heart needs to pump, generate cardiac output, and a blood pressure. Blood pressure needs to be high because of the waterfall. The waterfall leading to the CVP means systemic filling pressure. At the level of the organs, we have perfusion pressures. So when you preload, afterload contractility at the level of the kidneys, kidney perfusion pressure or renal perfusion pressure is key. And that's why it's easy to understand when abdominal pressure is increased, the perfusion pressure, the forward pressure will be diminished. And that's why, like in the Netherlands, they advocate, even in septic shock, to give nitroglycerin to improve perfusion pressure. Now, we spoke already about distribution, and we have to remember that all fluids administered will be lost to the interstitium. It's just a matter of time and a matter of osmolality and tonicity. The osmolality, with the formula there, will determine the tolerability, whereas the tonicity, or the effective osmolality of fluid driven by the sodium, will determine the distribution. Now, I already told you that most of the body is fluid, 2/3, and most of this is in the cells, and a little part constitutes the intravascular fluid. Now, what happens if you would administer 1 liter of isotonic saline and you check after 1 hour, only 25% will remain intravascular. If you would give a hypertonic solution like glucose or dextrose in water, most of this will go in the cells. So this is a good fluid for cellular dehydration, but not for intravascular filling. 8% will remain after 1 hour. Now, colloids, albumin, 5%, we assume that at least after 1 hour, they remain 100% intravascular. Now, the next D is drug, and we should not harm our patients. If we see fluids as a drug, you can only give them for an indication. One of the indications is to save lives, resuscitation fluids, like the sepsis guidelines. Second is maintenance, and this is to cover the daily needs of glucose, water, electrolytes as listed there. Third is replacement. These fluids should mimic the fluid that is lost. Upper GI losses, you can give saline. If there is a high hotspot in your stomach, then maybe isotonic balance is best. Nutrition fluids, and I agree I had to play a little bit with the R's to make it re-energizing nutritional fluid to cover the daily caloric needs. But when the gut works, please use the enteral route. And the fifth indication to give fluids, because we want to give other drugs like antibiotics. And when I speak with pharmacists, I don't know whether there are any pharmacists in the room, sometimes they dilute vancomycin 500 milligrams in 500 milliliters of saline. So the doctor thinks he's prescribing vancomycin, but in reality he's also prescribing 2 liters of saline every day. Now remember, all fluids are redistributed, so you have to reassess. Now Niels, my colleague from Antwerp, did a study on over 10,000 ICU patients, and they found that from all fluids, 3% is blood, 6 resuscitation, maintenance replacement 25, nutrition 33, and 33% fluid creep, as we already mentioned. So creep and maintenance is more than half of all fluids. Now the big fluid trials, they only focused at the 6%. And the latest trials comparing buffered and unbuffered or balanced versus unbalanced. So the difference is the strong ion difference, which is the difference between the strong cations minus anions. So for saline, it's 0. Physiologically, the strong ion difference should be 26 or above, and this is related to pH balance. You can also say that the difference is mainly made by the chloride level, and you can talk about chloride rich or poor for this or balanced, unbalanced and balanced. Now, a recent systematic review showed that there is a 90% probability that balanced solutions like Ringer's lactate, Hartmann solution, or plasma reduce mortality with 1%. And they reduce major adverse kidney events And especially if the patient received the right fluid in the ER, in the ICU, and later on, the impact is greater, especially in sepsis, burns, DKA, so diabetes, also severe pancreatitis, and patients with AKI, even if the potassium is increased, but not for TBI or neurocritical care. Now, one bag of saline already contains 3.5 grams of free sodium. Daily needs only 2.3. So one bag is a lot of crisp, is already too much. So maybe it's time to stop abnormal saline, as it has detrimental impact on sodium balance, chloride levels, kidney perfusion, acidosis, fluid balance. Potassium will increase, as I've stated. I don't know whether there are any nephrologists in the room, but a nephrologist used to tend to give saline if potassium is increased in AKI. So, what then is the ideal solution? I don't know either, but if you look at the CVVH 5-liter bags for hemofiltration, or 2 compartment bags where you add bicarbonate, this comes close to the ideal solution, and the strong line difference should be 24-26 to keep pH neutral. Now, maybe in the future discussion will be on the buffer or on how chloride levels are reduced with, you can see them, lactate, acetate, citrate, many buffers. The misconception is that we believe that they should generate bicarbonate, but that's not true. They have to exert a strong line difference because of the low chloride level. Now, next D is the dose. Paracelsus stated that everything is poison. You can have free water intoxication and die. Now, we looked at the composition of maintenance solutions in healthy volunteers and ICU patients. The healthy volunteers were nurses locked up in a hotel, and they were given maintenance solutions to cover daily needs. And you can see that when saline, the sodium balance is positive, as well as the fluid balance, also in healthy. So nurses accumulate about 600 cc after 2 days, ICU patients almost 1 liter after 2 days. So sodium with saline will result in a positive sodium balance and a positive fluid balance. That's why in Belgium, with a skip here, when you have the beer, you get the salty peanuts to make it more isotonic, more thirsty, you drink more, and you don't have to go to the loo. Now, duration is important. We shouldn't give fluids to treat the numbers. It's not because CVP, blood pressure, urine output is low, but because the patient is in shock and there is a VO2 imbalance. Now, the next T is about de-escalation. We should reduce the fluids when the patient is no longer in shock and gets better. Now, this brings me to the Rose conceptual framework. When there is a first hit, sepsis, burns, pancreatitis, trauma, fluids should be given liberally. Fluid balance should be positive to save lives, to recuperate. Now then comes the second bit, which is ischemia reperfusion. Fluid accumulation is a biomarker. We need to support the organs and stabilize the patients for a neutral fluid balance. So we need to save the organs and support the organs. And during evacuation, normally this goes spontaneously. Sometimes you need diuretics. And this, the third hit is the global increased permeability syndrome. Here we are going for organ recovery. Of course, when we are removing fluids, we must avoid hyperperfusion at the end. Hence the ROSE acronym, so it's like a flower, you water it, it blossoms, and the rose at the end is just a dry one. It's not a dead patient. I'm very happy to see that the ROSE concept, you can literally copy-paste this to any condition like neurocritical care, pancreatitis, burn patients, and so forth. So from patient rescue, organ support, to organ recovery. Now, what are the facts about fluid issuing, consumption, and stewardship? This is beautiful Northampton, where lives John Wilkinson, and he did a medical audit in internal medicine surgical patients, he found that we are giving patients 9 times too much sodium. Remember, sodium balance, fluid balance, and too little potassium to cover the daily needs. This, you may know, is the Little Mermaid in Copenhagen, where lives Anders Berner, principal investigator of the classic trial, and he looked at the issuing of isotonic solutions in Denmark and found that about 70% is saline and about 2 liters per patient. Now, this is a beautiful fight in Scotland, where lives Marshall McDougall, who was the first to implement the fluid guidelines, the NICE guidelines on fluid stewardship, and they were able to reduce saline. They replaced Hartmann with plasma light, and they introduced hypertonic balance solution for maintenance if needed at all. By doing so, they were saving annually a lot of money, and they reduced the average amount of liters of IV fluids per day to 0.3 and per patient to about 3 liters. So fluid stewardship allows you to reduce the issuing of fluids. Now, I told you in the beginning that you're never too old to study. I just finished a master in insurance medicine, and my master thesis was on a big data analysis. More than 4 million data lines that contain more than 1 billion individual fluid or drug administrations over a 10-year period in Belgium, and we were able to label the tonicity as well as the type and the indication of the fluids. I'm going to skip the statistics. We just did the basic description and comparisons before and after the European Medicines Agency PrEP recommendation to ban starch solutions, which was around 2012. Since then, we no longer use starches. Now, because it was a retrospective analysis, we had to define what is fluid for resuscitation. So we said if it's above 250 ml, half and 1 liter bags of isotonic solutions. Maintenance, anything that contains glucose above 250. Nutritional is clear. Dilution fluids were the bags of 50 or 100 ml of saline and dextrose in water, because we think that these little bags are used to dilute other drugs and contribute to the creep fluids. Together with drugs like paracetamol, which in Belgium comes in a flask of 100 ml, metronidazole, ciprofloxacin, these all come in ready bags with fluids. We defined some key performance indicators, like the number of admissions, how many liters per patient or liter per occupied bed day. For dilution, we want glucose, not saline. For maintenance, we want as little maintenance as possible. If needed, don't use saline, but use a hypertonic balance solution. And the drip fluids we calculated as the sum of the dilution and the medication fluids. So let's have a look at the results. During a 10-year period, we see that in Belgium about 11 million liters of fluids, and we see resuscitation is on the rise. As you can see here, creep fluids is the little bags and the medication. Maintenance is decreasing, but resuscitation is increasing. Why is that? We don't have more patients with shock or sepsis. The reason is probably ERAS, enhanced recovery after surgery, where crystalloids are favored. So a lot of our patients get Ringer's light or plasma light as a continuous infusion. So not as a bolus to save lives, but as maintenance. So basically they are given for the wrong indication. Now this is the trend in gray of 10 years. And you see in red before 2012 and in blue after. So you see that resuscitation fluids are on the rise, dilution, medication on the rise. And when we dive into resuscitation fluids in Belgium, We give more plasmaline than Ringer's lactate, and you can nicely see that starch solutions are decreased, but we are giving more albumin because we don't have any longer starches. This is just the KPIs that we spoke, the liters per patient. So remember Marshall McDougall, they arrived at 3. We are increasing at 5.6 and 0.75 a day. They were at 0.3. So we are giving a lot of fluids, a lot of dilution, and maintenance here is also is decreasing, so that's positive, and we are giving more balanced hypertonic maintenance, which is good. For resuscitation, we are giving too much, probably for the wrong indication, but we're giving more balanced than before and less saline. Now, if you look at the admissions in Belgium, it's increasing. The occupied bed days are decreasing, and we see the liters per admission. The overall trend is increasing as well as the liters per day. We saw differences, although Belgium is a very little country with about 12 million people. We have the north is Flanders and the south is Wallonia, so we have Flemish-speaking, French-speaking. We also have a German part, so it's quite a complicated country, but we see overall more liters per patient and more per day, and more in the northern part of the country than the southern part. And within the different regions and provinces, we also see huge variations and differences, as you can see on the right, sometimes 6.6 liters per patient, which is a lot compared to what Marshall McDougall in Scotland found. Now about the saline, there's a little bit of good news, but still we're giving 65% of all isotonic fluid is saline. So similar to Anders Perner in Denmark. This is the evolution between the 10 years of admissions and occupied bed days, but here you see that the liters we're getting more red, less green, and the saline per patient, the whole country is turning red, so this is not a good evolution. Now, where are the fluids given? Mainly at the wards, so it's not the ICU, it's only about 15%, but mainly on the medical and surgical wards, as well as geriatrics is on the rise. Now, where is given the least saline? This is in the burn unit, but also in the surgical department, probably because of ERAs, balanced crystalloids are given. So the internal medicine has about 80% still of saline, and similar to Denmark. Now, to discuss, we started with liability. If you miss fluid accumulation syndrome, you may miss abdominal compartment syndrome, you may miss acute mesenteric ischemia, and your patient will die, and you may be liable for prosecution. Because errors come when there is no indication for the treatment. So when you give a fluid, you must think, is it for resuscitation, maintenance, replacement, or dilution? Or when you give the fluids too late, patient is in shock, and you're beyond the first hour. Because every fluid that we give will result in second, third space accumulation, abdominal distension, ileus, compression of the vena cava, reduced blood flow through the heart, reduction in cardiac output, forward failure, and this may result in multi-system organ failure and dysfunction, triggering a vicious cycle of ongoing fluid administration. Now, fluid accumulation at the outside, the anasarca, the pitting edema, mirrors fluid accumulation at each and every organ, and this comes to the global increased permeability syndrome, where positive fluid balance leads to ongoing organ failure and fluid accumulation syndrome. You can see that all organ systems are affected, and this, I think, is a latent medical error. Because after rescuing the patient with goal-directed therapy, optimizing, and then going to stabilize the patient with late conservative fluid management and maybe late goal-directed fluids removal to evacuate and save the patients. Initially, we have our global macro hemodynamics, maybe PICO, passive leg raise, PPV. When these normalize, lactate normalize, we can stop fluids. And when there is an impact on organ function, the favorite is the lung water, abdominal pressure, plexus. We have to remove, and at the end, of course, avoid hypoperfusion. Problem is, there is no one single study looking at these different phases. That's why in this open access paper, please download it. We take a deep dive in the rows, and we propose some triggers when to start fluids, when the patient is in shock. You stop when, again, shock has resolved or the patient becomes unresponsive. You start removing fluids when there is fluid accumulation syndrome, and you stop removing when, again, hypoperfusion or fluid responsiveness occurs. Remember, it's the normal situation. So it's extremely important through this process of dynamic fluid phases to use the right targets, trigger safety limits in order to achieve the goal being avoid global increased permeability syndrome. Now, I cannot repeat enough that mistreatment, fluid accumulation syndrome may result in legal repercussions. So that's why we need to manage and take care of our patients. So we need to prevent fluid accumulation by restriction, to care, so it's support, organ support, and the cure lays in de-escalation and de-resuscitation. So prevention is restriction or withholding, so not giving maintenance when enough fluids are already given. Minimize free fluids, so we use a little bag. Most of the drugs can be given as a slow IV bolus rather than a bag or half a liter. Albumin colloids may allow us to reduce the total fluid intake, and studies have shown, like SWIPE and others, that cumulative fluid balance is less positive. I'm not a fan of hypertonic lactated saline because of the sodium load. Now, the care lays in the monitoring of the body weight, the fluid balance, maybe bioelectrical impedance analysis, maybe early vasopressors, remember the bottle squeezing, increasing venous return, and doing everything to lower abdominal pressure and to improve abdominal and organ perfusion pressure, maybe vasodilators in indicated cases. Now the cure is the de-escalation with the withholding or already withdrawing, and active fluid removal, which is de-resuscitation with diuretics, CVVH, or mobilizing with compression. So we hope with this approach to improve outcomes and save lives. Now, just to talk about dilution fluids, in this study, we see that dilution is usually for antibiotics, vasoactive drugs, electrolyte, sedation, that it is possible to reduce with 50%. And as I told you, many of these drugs can also be given, of course, not the vasopressors and inotropes, but many others can be given as an intermittent bolus. Now, just to translate this to the Belgian data, if we would implement fluid stewardship and reduce the amount of fluids per patient and per day, we could save at least $20 million. This is our Minister of Health who is seeking for 150 million of euros to save in the healthcare sector in the hospitals. So, to wrap up, ladies and gentlemen, I hope I convinced you that fluids are drugs. In Belgium, we are giving a lot of fluids, and fluids use is on the rise. We follow the BRAC recommendations not to use starches. Fluid creep is also rising, and balanced solutions are still underused. They were giving too much saline in some regions, which make us prone to medical errors. So I think fluid stewardship should be seen as a national quality improvement program, and just the example of Belgium, we could save about 20 million euros. Now the clock is ticking, we need to do better, so I hope when today or tomorrow you go back in the hospital and the family asks you, why is granddad so puffy and swollen, you're not telling that this is cosmetic and it's not important. Maybe it is an indicator or a biomarker of poor source control. Maybe you need to do an ultrasound or a CT to check for abscess or collection. So I think we can do better, and what we should do is the 8 rights, the right fluid dose, rate, duration, de-escalation, indication, patient at the right time. So I hope it was okay to show the previous slide. If not, I apologize, but it's just to state that we can and you can introduce fluid stewardship, as they are not innocent bags of water, fluids, or drugs. Implement the ROSE framework. Resuscitation, give isotonic balance, avoid maintenance, limit the fluid creep. If the gut works, give hypercaloric feeding. Remember, all fluids are redistributed. Maybe there is a place for albumin, especially if there is hypoalbuminemia. Restrict fluids when possible, de-escalate with withholding, withdrawing, and de-resuscitate when needed. Think about saline in neurocritical care. So remember the delicate balance between Scylla and Charybdis, hypervolemia and hypovolemia. So why wait? Start now. Join the Fluid Academy, become a member, become a fluid champion. The course is free, and you can gain 12.5 CME credits. Now, if you're a fluid champion, you can assemble a team of pharmacists, nurse, doctors, and build your path to become a center of excellence. We will list you on the map, and we have our first center of excellence in Kuwait by Dr. Abdul Rahman, and as well as in Saudi, King's College in Jeddah. So start your path, and we will guide you through the way how to obtain the silver, gold, or diamond label. So, having said that, I thank you for your kind attention, and I will see you in the online members portal.
Thank you, Mr. Mann. Thank you for your informative, wonderful presentation.
And of course, if there are any questions, I can take any question.
Thank you, Prof. Malumar. I want to ask about plasma light and normal saline. Is there a difference in clinical?
And congratulations to the organizers for this initiative, yes?
I will ask about plasma light balanced crystalline saline. Is there a difference in clinical practice between plasma light and normal saline? You hear me?
I cannot hear anything, so I'm not sure if there are any questions.
You hear me, please?
My audio is on,
Do you hear me, Prof?
but I cannot hear you.
Do you hear me now?
Yes?
Yes. Thank you, Prof. I want to ask you about plasma light. Plasma
I
light.
can hear, but in the distance. So maybe if there is a question, write it in the chat, and I can take it. Laura.
Yes. There.
Yeah, so that was the meta-analysis I showed. Mainly the comparison was between saline and plasma light. So for sepsis, for burns, for diabetic ketoacidosis, severe acute pancreatitis, AKI, even if potassium is high, balanced solutions are the first choice, not for traumatic brain injury. Now, if plasma light is not available, you can use Ringer's lactate, Hartmann solution, but the problem is that the sodium is 130, so it's a little bit hypotonic. If it's available and affordable, then the recommendation would be to use balanced solutions for resuscitation. I have a hard stop in 3 minutes. Yeah. Exactly. Yeah. Exactly, those are the difficult cases, and I think there monitoring is key. I don't know what is available, but if you have ultrasound, point of care ultrasound, to have a look at LV, but also right ventricular function, and titrate the fluids on that, in combination probably with a little bit of vasopressors, a little bit of inotropes,